Well, good afternoon and welcome to MedTech Crossroads, episode 75, Friday, September 17th, 2021. Well, we were back in the studio for a little bit, but I'm getting over something, so keeping my germs to myself. Also, our inimitable Steve, who runs our tech, is out on vacation today, and we are so thankful that he gets to do that. That's great for him. Today, the COVID news. We're going to go through quite a bit today on the COVID news because you asked us, you told us you like data. You don't want opinion, you don't want politics, you like data. Well, we're getting deep back into that again today, COVID Connect. After that, a new feature that we're going to do from time to time, which we're calling From the Mailbox. I don't know if anyone actually uses mailboxes anymore. Maybe it's FedEx or maybe it's text or maybe it's something else. But From the Mailbox, common MedTech startup questions. Oftentimes we'll try to do something themed, but what we're going to start to do with these sessions is just to bring some questions that come once, twice, or many times to us, unpack them with you so that you can understand what these startups are up against. After that, pitch party round 4, our third pitch of the season, Brian Stewart of HDO Health will be with us near the end of the show. After that, there will be time for Q&A, and we'll look forward to getting to that with you. So let's get to the COVID news. As always, our data comes from covid.cdc.gov. We're looking at metrics, we're looking at vaccine distribution, but first let's start with this news. This is from CNN, but you can find it everywhere. The meeting happening today at FDA, and a very succinct summary here, the two big questions the FDA will be asking in today's meeting on COVID-19 boosters. Those two questions, according to CNN, is vaccine immunity waning, and will boosters restore it? They note that data from Israel indicated that the longer out people were from their first round of immunizations, the more likely they were to suffer breakthrough infections. This is interesting, though. There's much less data about this from the United States, in no small part because the US CDC has not been tracking all breakthrough cases. We talked about this some months ago, that when they started looking at breakthrough cases, they explicitly declined to look at all breakthrough cases. Only the serious ones, serious enough to hospitalize or kill people. And that's a really important omission. This is also going to be the last public meeting, most likely, for Marian Gruber, who is stepping down next month, in no small part to the statements by the administration, sort of stepping past the FDA. So it'll be interesting to see what comes out of this meeting. They have made it very clear they don't want to talk politics, they just want to talk science. So hopefully that's indeed what happens. Well, there is a little bit of good news. It may just starting to be peeking over the horizon. It's not going to look very good from this graph, all red everywhere, except if I compared it to last week's, there's actually a bit of blue peeking through. We've reached what appears to be the bottom of the trough there on the combined transmission levels. So it will not surprise us if this begins to head in a good direction. Now, will it take a week or a month or longer? We don't know, but we can certainly say it's reached that trough, which is really, really good. Hospital admissions, and of course, this is exacerbated by the problem we keep hearing about, that staff just aren't there. They're not available. Some are quitting for different reasons, and hospitals are closing beds, which only makes this problem worse. As you've heard us report before, 20 beds out of 100 is basically the difference between a profitable hospital and a completely full hospital. And we've heard reports of local hospitals in our area shutting down 100 beds here, 120 beds there. That's a pretty big difference. Now, a little bit of good news here is that in that lowest category, the states where it's got the highest admission rate on average, there used to be 6 of those last week. There's only 3 this week. So maybe a little bit of good news there, but nevertheless, still a lot of red in the United States, exacerbated by the staffing shortages. Well, let's look at our dear state of Michigan. Still red pretty much everywhere, with one yellow county for the first time in a while. Probably an outlier, but we are reaching the bottom of that trough on the right side. How long will we stay there? Hard to say. If you look back at the 2 previous troughs, you can get an idea of how long we were in that trough before things started to come out. past performance, not indicative of future results necessarily. Let's look at new cases. Also, the possibility now that we are starting to peak over the top in the state of Michigan. We will see if that holds. Testing, the positivity rate is starting to flatline. We're getting there, which is also very good news. And deaths, while every death matters and our hearts go out to anyone who's lost someone from COVID, we are thankful that these deaths don't appear to be reaching levels that we saw during the first 3 pass-throughs in the state of Michigan. So a little bit of good news there. Again, don't get our hopes up, but some indication that we may be reaching a peak, which would hopefully leave us with nowhere but down to go. Same here with hospital admissions. We're starting to see that crest over at levels that are much, much lower in the state of Michigan than we had previously. But of course, if beds are getting shut down, then that just means that there's going to be more troubles with the hospitals. So even though that is a lower number, it doesn't mean that there are beds available to take those people. And the vaccination counts in the United States daily. We saw that peak in April, but it dropped to a low in July, crept up slightly here in August. It appears to be trending downward again. So certainly not the levels that many have hoped for. And this graphic, also from CDC of the state of Michigan, one that we've reported on for the last number of weeks, per 100,000 population, if you have a high vaccination rate, that's the top row in the key on the bottom right. And if you have a low vaccination rate, that's the bottom row in the key on the right. Or if you have a high case count, that's the most rightmost vertical column, or a low case count, that's the leftmost vertical column, you can get a sense where the state is falling. And unfortunately, probably a majority of the state is in the 40 to 100% vaccinated and high case rates. So not seeing a lot of correlation there, but it is continuing to pass through, as we saw from that other graph. Well, I wanted to look a little bit more at this. One of the questions that comes up is, how does this stack up to things US-wide? We showed this for the first time in recent memory last week, and this is excess deaths in the United States. There's roughly 55,000 deaths in the United States every week of the year. Roughly 55,000 people die. Now it goes up in the wintertime and down in the summertime, but on average, that's about where we are. The yellow line is the statistical significance line, meaning if you get above that, something's happening, something's changing. And of course, the flu season of September 2017 into 2018, something statistically significant happened. COVID, something statistically significant really happened. And we're coming up on what amounts to a 4th wave here nationwide in terms of COVID deaths. But if we break this down a little bit further, CDC also has data on how these deaths affect different groups by age. The 2015 through 2019 data is shown in gray, the 2020 data in red, and the 2021 data is in orange. You can see that for those under 25 years of age, the statistical risk of death from COVID has not really gone up since pre-COVID. Marginally, as you climb to some pretty high levels at some very specific times during the pandemic for the older age groups. But deaths aren't the whole story. As we often talk about, what about long COVID? What about the things that happen that make you say, I don't want to get this, because it's not just about death, it's also about hospitalization. It's also about other symptoms. And those are important questions. Well, first of all, one more thing on deaths. Let's break it down by age groups. This from the CDC as well. The 65 and over age group for COVID deaths accounts for nearly 80% of the roughly 650,000 deaths we've experienced from COVID in the United States. Nearly 80%. The 45 to 64 age group, just about 20%, leaving about 3% or 21,000 deaths in the under 45 age group. So the risk of death to those under the age of 45, quite low comparative to weekly death rates in the US, about a half a week's deaths in the US. But deaths aren't the whole story. Let's talk about hospitalizations by age bracket. And some really interesting things emerge. This is the first time we've shared this on the show, and I hope you're as interested in it as I am, because what we've seen is some interesting changes over the course of this pandemic. Of course, last winter, if you're 70 plus years old, it was a relatively deadly winter, and in this case, hospitalizations, relatively high chance of being hospitalized. It was 1 in 5,000 probability. If you were 70 years or older and you just rolled the dice without consideration of comorbidities, et cetera, there was about a 1 in 5,000 chance of being hospitalized. That's actually dropped to here in August. There's now a 1 in 11,000 chance of hospitalization for those 70 years and up. Of course, the sad part of that news is we've lost many people in that demographic who aren't going to be coming back, and so they're not part of that population. When we look at the 60 to 69 year demographic, there was in January about a 1 in 11,000 chance of being hospitalized. Again, if you just roll the dice, we're not talking about comorbidities. We're not talking about anything specific about the patient, just their age. But that has actually come down as well. There's now about a 1 in 16,000 chance of hospitalization, rolling the dice if you're between 60 and 69 years old. In the 50 to 59 year age bracket, that's where things start to flip. There's currently a 1 in about 18,500 chance of hospitalization. But that's unchanged since the month of January. The risk this late summer is about the same if you're 50 to 59 years old as it was last winter. And this marks a change because we're seeing the older demographics, the risk of hospitalization is dropping. At 50 to 59 years old, that starts to plateau out. And now we're going to look at the age brackets underneath. To 49 year age bracket, there's currently a 1 in 25,000 chance of hospitalization. Again, you're rolling the dice just saying I'm a member of a population. We're not going to talk about comorbidities or risk factors or underprivileged populations that have higher risks. But if you just roll the dice in this age bracket, which is the one that I fall into, there's a 1 in 25,000 chance of hospitalization. But that's up from a 1 in 33,000 chance of hospitalization around January of last year. The probability of being hospitalized in this demographic, while it's still exceptionally low, is much higher than it was in January, which is interesting. And that trend continues as we move forward. In the 30 to 39 year age bracket, there's a 1 in 36,500 chance of hospitalization. But that's gone up markedly from a 1 in 51,000 chance in January. So again, not quite doubling, but the probability of hospitalization for a given age bracket is actually going up for those under the 50-year mark. We haven't heard this talked about a lot in the media. It's still a very small number, but it's heading in a not particularly good direction. In the 18 through 29 year age bracket, so we're not quite considering pediatric patients here, pediatric patients obviously under this age, there's a 1 in 70,000 chance of hospitalization. That's up from 1 in 88,500 in January. So again, if you're part of that population, you roll the dice. What's my chances of going to the hospital during this pandemic, during this length of the pandemic? It's about 1 in 70,000. but that number is going up. And this is also true for the youngest demographic, 0 to 17 years, where there's, we'll say, only a 1 in 200,000 chance of hospitalization. But it's actually up quite a marked spike from 1 in 333,000 in January. So while these numbers are very, very low in an absolute sense, they are moving in a higher direction. Now, the number there, 1 in 200,000 versus I think we were seeing for the oldest demographic, 1 in 5,000. So quite a large difference between those. We have a Q&A here from our friend Ken. We have a statewide, do we have a statewide and or national data on what percentage of hospitalizations are unvaccinated? Do we then have vaccination rates by age group? Then is there a correlation to increased chances of hospitalizations due to less percentage of people getting vaccinated in those younger age groups? Ken, that's a great question. I think that bears looking into. That data is generally out there, but it's hard. You've got to do some digging to get to it. We'll take this as an indication. That might be a good thing to look at next time we present this data to see if this trend of younger folks having higher rates of hospitalization does correspond to lower vaccination rates or not. We know that older folks have tended to get vaccinated more readily, which makes sense given the risk factors, and we'll have to take a look at that. So Ken, thank you for that question. That's a great one. We can't present that data today, but we will certainly take a look at that. One of the major frustrations, of course, in this whole thing, when you compare us to Israel, for example, is that in Israel, when they talk about exposure and things like vaccine passports and everything else, which gets into political questions that we'll stay away from and stay on the science, they look very, very carefully at vaccination, be it partial or complete vaccination, exposure to the virus, a good solid infection, and negative tests, all of which are indicative. And it's something that we in the US have sort of declined to look at. So I think it's a great question, Ken, and as we have ability in future weeks, as we touch these topics, we'll start to ask that question, because this is kind of new for us to see things broken down so clearly in this way. There's a ton of data the CDC does have. It's there for the digging, and we'll continue to do that with you. Great question. We appreciate that. Well, next up, some local announcements. I want to make sure you are aware of the Renaissance Venture Hot List and Undemo Day. Jeff Reinfeldt passed this on and wanted us to keep announcing it on the show. The Hot List and Undemo Day is back in virtual for fall 2021. The Hot List is a curated list of best early stage companies that are doing venture fundraising in the next 6 to 12 months. If you're selected for it, you're going to get to connect with hundreds of venture investors from around the country, which is a pretty good thing to be put on the show by Renaissance Venture Capital. So quite an opportunity, and there's no cost for it. So there's no cost to attend or apply. I have a little bit more data on that here. The deadline for that is Monday, September 20th, noon of Monday, September 20th. So you still have time to apply. They will look at the data set, obviously, before approving it. And they're looking for about 50 or maybe a few more companies for that. In the spring of 2021, they hosted over 500 meetings. So you can apply at renvcf.com/hotlist-application. Get to that Undemo Day and see what you can do. What a great opportunity. You got to get out there. Like we like to do with our pitch party, much lower level thing, right? We like to get people exposure to pitching, get them feedback, get out there and demo. It's a really important step. Speaking of demo days, Our friends at Accelerate Health up in Flint this time are having their demo day on Wednesday, September 22nd. It's a virtual event. It's only for an hour and a half, so it's one that should be relatively easy to make it to. And that will be on Wednesday, September 22nd, the Accelerate Health Flint Demo Day. See if you can make it to that. Support the local ecosystem. Of course, Flint getting off the ground there with MedTech. Really cool to see. That's some of our local news. Of course, the Ann Arbor Biosocial had their event last week, so good to see them getting that going again. Next up, we're going to do something we're calling From the Mailbox. And these are common MedTech startup questions that we receive. Now, if we're back in the studio, I think I'd get a nice mailbox sitting there next to me and maybe reach in and pull out some letters. Of course, these don't come through letters. These come through emails from potential clients, from discussions with clients. And oftentimes, a large part of our job at Into Being is educating people so that they know what the landscape looks like. Half the battle is just understanding, and a much smaller portion is then executing it. Well, here's the first one we're going to talk about today. My regulatory consultant looked at our medical device and told me that we are a Class 1 exempt product. This means we don't have to do anything for FDA except register and list, right? And we've actually received this question on multiple occasions. Let's start here. The first thing is, if your regulatory consultant is not telling you what the implications of your classification are, there is a problem here, because how you walk, what you do, how you develop your device is the direct outgrowth of that information. So first of all, that's a warning sign, but we've seen it happen many, many, many times. And then specifically, there's this perception that if I'm Class 1 and the word exempt gets thrown around a lot, then there must not be too much I have to do. And of course, many times, companies are motivated to ask the regulatory classification question because an investor is asking for it, or somebody wants to see it, and so they think, well, I got to go get a piece of paper. And they get the piece of paper, and then they start reading it, and they realize they don't know what it means. They don't know how to implement that in the actual development process. They don't know what to tell their designers and their engineers. And they see the word exempt, and that sounds really good. That sounds like a really good step to take. But what does it mean? Well, let's look at this. So in general, you can break down the medical devices in the United States into Class 1, which is the lowest risk, lowest burden device, Class 2, which accounts for many, many, many devices in the country, and Class 3, a much lower percentage. Now, there are different requirements, and there's 3 places on the first line for Class 1 where you see the word maybe. That's where this idea of exemption comes in, and we'll talk about each of these as we go through. So for a PMA, or a pre-market approval, this one's easy. Only Class 3 devices are subject to pre-market approval. Class 1 devices are not, Class 2 devices are not. Those are regulated differently. And so you're in a whole new world when it comes to Class 3 devices. That's an easy one. We got that one out of the way. What about 510Ks and de novos? These can be confusing, and they often seem similar but different. Well, it turns out that they are possibilities for devices in both Class 1 and Class 2. Again, PMAs are exclusively the domain of Class 3, but there's a chance that you could have to submit a 510K for either a Class 1 or a Class 2 device. And this is the first potential meaning of the word exemption. You might be exempt from the 510K process, or you might not be exempt from the 510K process. How are you going to find that out? Well, it turns out that in the classification that FDA has on their website that describes the type of product that you've identified and are going to be pursuing substantial equivalence to, they will actually say you are exempt or not from the pre-market notification requirements. Then they throw some numbers around. Well, that's good news. That means that you don't have to file with FDA for clearance. You don't have to ask them, FDA, may I please have permission to put my device on the market? If you're exempt from pre-market notification, also called the 510K process. That's one form of exemption. There's also something called general controls, and all medical devices are subject to general controls. And we won't belabor those here today, but suffice to say, if you're not familiar with general controls, you should familiarize yourself with it because every class of medical device is subject to those. Then there's what's called design controls. And this is something that we talk an awful lot about on the show. It's an overlooked part of the development process. Design controls has to do with defining your inputs, your outputs, your verification, your validation, your design transfer, doing those in a documented way through a process that FDA has come to expect. It's good practice no matter what, but you're certainly not going to go to the same level if you don't have to. So do you have to? When? Sorry about that, little technical difficulty there. When are design controls required? Well, for class 2 and class 3 devices, they're required. There's really not a way out of design controls, with very, very few exceptions. But in class 1, it's a maybe. And this is the next important use of the word exempt, because it's possible that you can be exempt from design controls. In fact, most class 1 devices are, except for a very small list that's listed in the FDA's regulations, as well as ones that are, quote, automated through computer software. So if you have software in your device, but you think you're class 1, beware, you might still be subject to design controls. It's something to watch out for. But that's the second use of this very important word, exempt. You may be exempt from design controls, you may not be. You may be exempt from the 510K process, you may not be. The last use of the word exemption is from Good Manufacturing Practices 21 CFR 820 itself. If you're class 2 or class 3, probably not. But in class 1, there's many times where the FDA says you are mostly exempt from GMP. Usually that's with the exception of complaint files and record keeping and procedures for those. But that's another use of the word exemption. So if you've had someone haphazardly say, you're class 1 and exempt, now you know, exempt refers to as many as 3 things with the FDA. Which one is being referred to? Because it could be any of those. Now finally, it comes to registration and listing, because registration and listing is always required with the agency. You have to tell them you're going on the market, usually within 30 days of first sale, and you have to pay them a fee. Tell them what they can come to you for, what kind of device you're selling. That's always required. But one more word on that. Often companies get misled because they think that registration and listing are actually part of FDA's clearance or approval process, or that they communicate some kind of goodwill on the part of the agency. Registration and listing is just an activity that you can do at your web browser and have your checkbook in hand. It really doesn't communicate anything. It's those things like the 510K, like the de novo, like the PMA, like the documentation in your file for your design controls, like a successful audit by FDA after you've implemented GMP 21 CFR 820. Those are the things that hold weight, not activities like registration. So the next time you hear somebody say, oh, this company is FDA registered, well, step back for a moment. That's not the communicator of value. It's these other things, many of which you can be exempt from. And it's important to know which you're exempt from so that you know which you're not and which you need to implement. Well, that's the answer to our first question from the mailbox, our inaugural question from the mailbox. This next one is one we get with some regularity. And of course, companies like Fitbit and Garmin are selling heart rate monitors, among other things, as health and wellness devices not as medical devices. And the companies will come and they'll say, how do I tell FDA that I don't want my device to be considered a medical device? I don't want to have to be considered a medical device, and they didn't have to be considered a medical device. So what do I do? Well, I wish it were that simple. It turns out that there are specific carve-outs for these things called health and wellness devices. In general, though, your device is classified on the basis of its intended use and indications for use. What you say the device is good for and what situations it can be used in. So what that means is how you market it, how you advertise it, how you talk about it has the most to do with how it's going to be classified and whether it's considered a medical device. Because a medical device is something that's used in the diagnosis and treatment of a disease state or condition. And it's not metabolized because that would be a drug. So first of all, we don't get to choose if our device is a medical device, except by choosing what our marketing claims are. But that being said, what if you are interested in health and wellness? What if you'd really like to avoid having to go to FDA for those first products that you want to sell? Well, there is some cool guidance that came out recently in 2019 anyways. That was just last year, right? Because 2020 doesn't exist. The General Wellness Policy for Low-Risk Devices issued on September 27th of 2019. The agency says, for the purposes of this guidance, the Center for Devices and Radiological Health defines general wellness products as products that meet the following two factors. They're intended for only general wellness use, as defined in this guidance. We'll talk about that in a second. And they present a low risk to the safety of users and other persons. General wellness products may include exercise equipment, audio recordings, video games, software programs, and other products that are commonly, though not exclusively, available from retail establishments, including online retailers and distributors that offer software to be directly downloaded, when consistent with the two factors above. Only for general wellness use, low risk, generally retail oriented. Of course, exercise equipment can be classified as a medical device, as can any number of other things. But this is where they start to draw this line for this particular category. What I want to share with you next is a little bit more out of that guidance. So I'm going to do a screen share with that. And here we have that general wellness guidance policy. I'm going to take you down to some interesting sections of it to talk about what these things are. The first category of general wellness intended uses involve claims about sustaining or offering general improvement to functions associated with a general state of health that do not make any reference to diseases or conditions. For purposes of this guidance, this first category of claims relate to weight management, physical fitness, relaxation or stress management, mental acuity, self-esteem, sleep management, or sexual function. So if you were saying, we're going to help you maintain a healthy weight, this wouldn't be a bariatric surgery product, right? It's actually going to do something to fix a discrete problem. This just helps you maintain what's healthy. Or claims to promote relaxation or stress management, or devices that improve your energy. These are the kinds of things that can fit into wellness. Learning capacity, promoting physical fitness, sleep management, self-esteem, building your muscles, improving performance, improving general mobility. Now you've got to be careful there because wheelchairs, of course, and things like that are going to be considered medical devices because the person is not able to do the thing. But if you're just improving mobility, for example, a car is not a medical device, then you have opportunity to fit into this category. Recreational activities. But let's look at some that are not considered general wellness claims. If you are going to diagnose or treat obesity, that's not a general wellness product. If you're going to treat an eating disorder, a diagnosable eating disorder such as anorexia, that's not a general wellness product. What about anxiety? Well, if we can diagnose it and treat it, it's not going to be considered a general wellness product. You get the idea. Autism, muscle atrophy, claims to restore structure or function, impaired due to a disease state or condition. There are the magic words again. A medical device is something that is used to diagnose or treat a disease state or a condition. So if you're making reference to diseases and conditions, watch out. That's where these products get into trouble. It's only when you can keep your claims free of these things that you'll find yourself in a happy place, able to move forward with health and wellness without tripping over that FDA medical device line. And there's nothing wrong with it. There's nothing wrong with going out there and marketing a device with claims that work for your market. We love to work with companies on medical devices. But if you can meet your goals and stay in the health and wellness category, do it. It's a good thing. So hopefully that helps a little bit with that question. Another one that we get very, very frequently. And the last question from our mailbox. Our team hasn't decided yet which technical approach to take for a part of our product. I want to start, and this is usually the CEO talking, I want to start on the FDA development process, but I don't want to start too early. When should I begin that process? Again, our third question for today, and one that is very commonly comes through our doors. And it's a great question because I feel like 5 or 10 years ago, companies were not cognizant of this. They often wouldn't understand that FDA was part of their process, or they would commit too early. And now we're seeing companies ask, when is the right time? How early should I start that process? And the answer is not as early as possible, nor is it as late as possible. There's an actual answer here. And it starts with the FDA's QSIT, the Guide to Inspections of Quality Systems, where they tell their inspectors that the firm that they're inspecting, the firm's development of concepts and the conduct of feasibility studies are not subject to the design control requirements of the regulation. However, once the firm decides that a design will be developed, a design plan must be established. A firm will determine when it begins to apply design controls. However, design controls must be applied no later in time than the firm approves its first set of inputs. Let's break this down just a little bit. You've all seen the design waterfall going from user needs all the way down through design input, the design process, design output, the finished medical device, design inputs and outputs being compared by verification, user needs and the finished medical device being compared by validation, with reviews happening all throughout the process. Well, that's great, but when do I get into that? And what the FDA has said is once you have approved a set of inputs, once you have approved your first set of design inputs, that's when this control really comes to bear. But they also said the development of concepts and feasibility studies are not subject to this kind of rigor. So give yourself that sandbox. Give yourself that sandbox. We've had clients ask us, how do design inputs work? Because I haven't decided on my design yet. And of course, what happens there is the design inputs can inform your design output process. In this case, here's a breakdown of how intended use flows into user needs, risks, standards, and requirements. Only after those are considered can you begin to think that you might be done with design inputs, review it, and go on to your design outputs formally. It's only after you've thought about all these things that FDA says that's when you better really start the process in earnest. So enjoy that sandbox while you have it, use it, and don't forget to start thinking about things like your intended use, your user needs, your risks, your standards, and the requirements related to them. And after that, as those start to solidify, that's when you'll want to enter the FDA process. Well, that's it for our first installment of From the Mailbox. Next up is our $2,500 quarterly MedTech Crossroads pitch party. We call it a pitch party because with the companies in different verticals, it's not a true competition, but we want these pitches to wow our judges who will be with us next week. We want them to wow them. We want them to be able to tip their hat to one and say, you know, they all had the information I was looking for. Well, maybe not, but we'll talk about that. I want to educate on what they liked, what they didn't like, and then tip their hat to one that they just thought was better than the others. And so that's the goal of this, mostly for education, but also there's a $2,500 prize from Into Being. Into Being does not participate in the voting. Our independent community judges do the voting. If you want to participate, not this time around, but next time around, send those pitch decks to pitchparty@medtechcrossroads.org to be eligible for selection. Areas of problem statement, vision, value proposition, team, milestones, business model, competitors, and your ask or the functionally equivalent areas. Of course, our judges, Andy Rader, Dr. Nikki Kennedy, Jim Metzger, and Stacy Frankovich will be with us next week talking about the pitches we've heard these last few weeks. And with that, I believe he's here with us. I want to welcome Brian Stewart of HDO. I get that right, Brian?
Correct, HDO Health. Thank you very much for inviting me. Glad to be here.
Brian, thank you for being with us. So what we're going to do is we're going to put 10 minutes on the clock. We're going to have you get your PowerPoint up right now. And once that's all ready to go, I'm going to drop out. We're going to let you present. There will not be any questions afterwards. So make use of your full 10 minutes. And we'll look forward to hearing about HDO Health. Afterwards, I'll come back on and you and I'll chat for just a minute. Shortly after that, we'll have Q&A from the audience about any other topics we've had on the show. And then we'll go from there. How's that sound?
It sounds great. Thank you so much.
All right, we're putting 10 minutes on the clock. Brian Stewart from HDO Health.
Thank you, Gene, and thank you for this opportunity to share a little bit about HDO Health. As you see on the screen, we make medical devices that help prevent people from bleeding to death. Here's our disclaimer statement for today's presentation. The problem we're addressing is exsanguination or bleeding to death. As you see from this slide, it accounts for up to 90% of preventable combat fatalities and about 40% of preventable civilian trauma fatalities, with almost 18% of those trauma fatalities due to hemorrhage from the torso appendage junction. And for those non-medical, non-clinical folks, that's where the leg meets the hip or where the arm meets the armpit is the specific area that we're addressing with our first technology. Also, you see about 90% of trauma victims suffer from uncontrolled bleeding before reaching a definitive site of care. And the currently available products have some significant cost and design limitations. So our solution, our value proposition is the HDO Health Junctional Tourniquet, what we're currently calling the Journiquet. As you see, it's a novel Class II medical device that we believe significantly innovates on currently available products in the market to quickly stop bleeding more effectively and efficiently in those hard to reach and treat junctional regions. And you see, we believe we have a compelling value proposition for end users, including some of the points you see below. Number one, we believe our product is a very user-centered design. And I'll talk about that a little bit more when we talk about our team and our co-inventors and our co-founders. But it's a non-invasive, non-surgical solution based on very specific user design feedback. Certainly know that the device can save time and application, currently estimated between 20 and 30 seconds in high stress, combat, and trauma environments. And by design, the device only requires gross motor movements to manipulate and apply, even when wearing tactical or medical gloves in a wet environment or a traumatic environment to help stop bleeding while the patient is still in the field. We know that our device is very easy to use. We recently had the opportunity to show our version 2 prototype device that you see pictured here on the screen with a cohort of not inexperienced users, but we essentially gave them the device with no instructions, no prior knowledge, and said, use this device. They were all able to quickly and effectively use the device as it was designed. Another design criteria is we want the device to be affordable, approximately a 10 to 15% discount to devices that are currently on the market. In addition, the device needs to be very secure in transit. Once the bleeding has been stopped in the field, the device needs to stay in place and be very secure while the patient is transported, whether it be through an ambulance or through a helicopter to a secondary or tertiary site of care. Lastly, the device needs to be as portable and durable as possible, pre-assembled as one device with not a lot of assembly required, easily stowed, very durable for harsh environments and harsh operating conditions, and also to be very compatible with current tactical medical bags, both from a stowage and a deployment situation. In terms of our market opportunities, you see here, we believe we have a very large, diverse market to go after, with the total available market just over 3 billion, based on 8.4 million units. You see a fraction of that defined in our SAM, a fraction of that defined as our SOM, and our initial beachhead in terms of the market is specifically around combat medicine in the military. We have some contacts and points of contacts, both in the Air Force pararescue teams, several of the SEAL teams, Marine Corps Raiders, special operations teams as an initial entry point, as well as the Ohio First Responder Network that is directly related to some of our co-founders. You see the chart on the right list, our TAM and SOM by the market segments we have identified. One point of note you'll see at the bottom is that these values are calculated by the number of units times an average selling price of approximately $360, which is the average of the currently available products on the market. So a little bit about HDO Health. We are commercializing our first medical device, this Journiquet technology that we're commercializing in partnership with the Ohio State Innovation Foundation at the Ohio State University. And our vision is to build a team and company that's united by this vision of helping save lives, that's guided by very common values. We want to develop and bring to the world innovative, life-saving, cost-effective medical devices. And from a values point of view, as you note our name, HDO Health, that's derived from our company being heart-led, data-driven, and outcome-focused. And we feel like those values and that story is really what will drive us to be differentiated in the market. Our near-term goal is to provide the world the most effective, affordable, and easy-to-use junctional tourniquet to prevent people who have suffered a traumatic junctional wound from bleeding to death. Our founding team, I'm Brian Stewart, as you see, the founder and CEO. I am a former Marine Corps infantry officer, and I have a 25-year plus career in healthcare in multiple market segments. I'm also certified in private company governance. I'm very active with the Private Directors Association. My other co-founder, Tanya Noseri, is a PhD in biomedical engineering. She's a professor at Ohio State. She's also one of the co-inventors, very prolific in other multiple invention disclosures, as well as the founder of the combined BS, MS degree program in medical product development at Ohio State. Dr. McElroy is another co-founder and co-inventor of the device. As you see there, he is a general trauma surgeon. He is also a SWAT medic on the Ohio County Department in Ohio SWAT team, and is also a tactical medicine trainer. And last but certainly not least is Nadi Graham, who is another co-founder and co-inventor of the device, who currently serves on the special response team of the Ohio State Highway Patrol, is a SWAT medic, and as well a very prolific tactical medicine trainer, both him and Dr. McElroy, both in the state of Ohio and around the nation. So that is our current founding team. Current timelines and milestones. Our Journiquet is ready for additional clinical testing in a perfused cadaver model, as well as additional end-user testing to accelerate our final product design, a process getting an FDA 510 clearance, and ultimately commercial availability. We did complete a technology validation and startup fund phase 1 grant funding cycle from the state of Ohio at the end of May, which resulted in the product being at technology readiness level 6 as defined by the Department of Defense. And we currently have 2 working version 2 prototypes that incorporated all of the user feedback we gained in the first phase of our development, as well as another cycle of user feedback that we gained at the Ohio State Medical Simulation Center. So we're currently in phase 2, which is our regulatory and commercial strategy development. You see there are major phase 2 milestones. We are in the process of forming a very experienced and helpful advisory board, working on the final product design and development in preparation for our 510K Class 2 filing and clearance. In addition, we have had some initial conversations and ongoing discussions with potential contract manufacturing and distribution partners for our device, as well as working on our market entry and commercialization strategy, in addition to our capital access strategy, development and execution. A brief overview of intellectual property. As you see, we did have an initial positive IP assessment with the provisional patent filed early in 2020. That rolled to a non-provisional patent in early 21. And then more recently in May, the patent was actually filed and made public on the US Patent and Trademark Office website. So it is pending further review and assessment from the PTO. In terms of our business model and go-to-market strategy, we do anticipate following a multi-channel distribution strategy, both direct sales via e-commerce, traditional business development, and other Department of Defense and government contract vehicles, as well as indirect distribution via distribution agreements or licensing partnerships. As you saw from our TAM, we do have about a dozen market segments. We've categorized them into 4 buckets, with the first being the DoD military first responder market, where we intend to establish our beachhead in combat medicine, as well as with the first responder community, particularly in the state of Ohio, given the influence and impact of our 2 co-founders and co-developers of the technology. And then additional market segments are around healthcare with hospitals, the entire AED market, stop the bleed stations. And then unfortunately, given what's going on in our society, we intend to position this for K through 12 schools, universities, churches, stadiums, anywhere where there's large groups of folks gathered that may have a traumatic event. And lastly, the civilian community, both the prepper community that's focused more specifically around this, as well as the general US population. Here's a quick review of the competition. You see the key features, the time to apply, and the projected commercial costs, and how our device compares to the other 4 devices that are currently on the market. Our ask to date, we received $150,000 on our first TVSF grant that we completed that cycle the end of May. The $2,500 from this pitch party we would intend to fund our regulatory consultant fees related to our 510K strategy and submission. We are seeking an additional $300,000 in non-dilutive grant funding from a phase 2 TVSF grant, as well as a Rev 1 OSU Innovation Fund. And then ultimately, we'd like to seek $750,000 in a seed round, partitioned out as you see here, to allow us to be well positioned from a revenue growth point of view for a Series A funding round in 18 to 24 months. Here's my contact information if you'd like more information or have questions about our company or about HDO Health. And thank you very much.
Brian, thank you for that presentation. So one of the things that we always, and I think maybe it's partly because we've been doing these things all virtual and COVID, and people oftentimes need motivation. And the one question that I always ask our presenters afterwards is, tell us just a little bit more about what it is that drives you to do this. Because doing startups is not easy. Same thing I say to every one of them. Doing startups is not easy. Each person has a personal passion, why they're doing it. What is yours?
I anticipated your question from looking at other pitches, and that's what the heart-led, data-driven, and outcome-focused on this slide are about. For me, it's twofold. One, wanting to create something that impacts lives. And certainly we believe this technology in this company, if we can prevent just one person from bleeding to death from a traumatic wound, particularly those in our society that are war fighters, those that are in the military or first responder, if we can just save one life, then it certainly would be worth it. But for specifically around our company, we want the company to be heart-led, meaning we're very principle-focused. We want to honor and respect our first responders, the folks in the military, and be very specific about what we're about as a company and what we're not about. For example, wanting to source all of our products in the United States versus overseas, even if that means reduced margins for our company. Second, we want the company to be data-driven. We want, certainly our device has to work when it's supposed to work. So anything that we produce, starting with the Journey-Kit or any other medical devices, we want to be well supported by data. And lastly, we want outcomes to matter. Certainly in the case of stopping bleeding for someone that suffered a traumatic junctional wound, as I mentioned, the device has to work when it's supposed to work. So our desire is to be outcome focused. So it's really about helping other people, saving lives, and building a company that's principle focused, mission driven, that helps impact the world in a positive way. That's really what drives me and our team at HDO Health.
Brian Stewart, co-founder, chief executive officer, HDO Health. Thank you for being with us today.
Thank you so much. I appreciate the opportunity.
We will look forward to next week when all the pitches are judged with our judges on the show. Hope you can join us back then for that. Comments and feedback will be forthcoming. What we're going to do in this last minute that we have here together is we will ask our audience if there's any questions you have on things that that we talked about on the show, or I think other community events that maybe need to be announced. Those are often wonderful to get in so people know about them. We'll give just a minute for that. Feel free to raise a hand, stick it in the chat, or stick it in the Q&A if anything like that is on your mind. Again, this isn't all about us. We want to help the community move forward. So oftentimes people will pop in with that. Feel free to do that. We'll give it about 10 seconds more. And not seeing any of those today, what we're going to do is say goodbye. Oh, wait, hold on. We do have one. I see a Ken Spencer with that you should be live there, Ken.
Yeah, so Gene, what a terrific show. I mean, this is packed full of great information out there. So I really appreciate it. So totally on the other side of the spectrum of, not useful information. How did your Apple choice go? I think you were going to go back to your team and decide.
We didn't get the team. We didn't. Listeners from last week will recall that when we had Eric on, we had gotten into a conversation about types of apples that are likable. I don't know if we talked about it last week, but there is this big question in the U.S. as to why is Red Delicious actually a thing? Because nobody likes it, and yet it's a thing. We did find out.
Yeah.
That was you, Ken. Thank you so much. Yeah, Ken, that was amazing because the implication of that was that Red Delicious basically got changed because people liked the deep red color better and they ignored the taste, and that's how we got where we are. So yeah, thank you for that. We are certainly into apple season, and that was a real fun addition. Are you getting to any cider orchards this year?
Not in South Carolina. We're into peaches down here.
Ooh, well, those are good too. Enjoy those peaches, and let's see if no one else has anything. We're going to call it a day for today, but get out there and enjoy this fall that's rapidly coming upon us. It was a great day. We'll talk to you next week for the pitch party judging on MedTech Crossroads. Thanks for being with us. Bye-bye.